Well, Laura, as you know, we're doing a series of interviews within the ISHLT of people like yourself who are pioneers in one way or another in the field of heart and lung transplantation mechanical support. So perhaps we could begin with some discussion about your early days and what really led to your entree into transplantation and immunology.
Well, I started life as a field biologist. I'm not sure you know that. And I was very interested in biology more than medicine. But I became very interested in muscle biology as an undergraduate. And that kind of led me into the human as opposed to the previous interest in the animal side of things or the other animal side of things. And then I finished my training in pediatrics, and I was interested in pediatric cardiology in particular, spurred on by a wonderful mentor by the name of George Emanuelides, who really set the stage for me to go into cardiology.
And where were you during that phase of your training?
I had gone to medical school at Tulane University in New Orleans, and then I did my pediatrics training at Harbor UCLA Medical Center in Los Angeles, where Dr. Emanuelides, or Dr. E as we all knew him, had an enormous impact on pediatric cardiology. He had trained at the Hospital for Sick Children in Toronto, and so that seemed to me to be a wonderful place to train in pediatric cardiology. And so I headed up to Canada to begin my training in heart disease in children.
You know, at some point you veered off into the immunology and transplantation world. You also spent some time at Oxford. Tell us about that.
Well, I finished my cardiology training in Toronto, and at that time we had just started. So during those years in the mid to late 80s, children with a single ventricle malformation, such as hypoplastic left heart syndrome, basically just died, and there wasn't a lot to do for them. And the surgical palliation attempts were not, at that point, yet meeting with much success. When I finished my training in cardiology, therefore, this was a population that was really, there were very few options for them. And that's about the same time that Len Bailey had performed and reported the first successful infant heart transplant. And so this seemed to me to be a wonderful opportunity for the future for these children. And so I set off to England to learn about transplantation from the point of view of the immunologic side, because it seemed to me that there were going to be potential opportunities that had yet been unexplored in dealing with this evolving patient population, that is the young child and infant who underwent heart transplantation.
You spent time with Catherine Wood?
That's right. I spent 4 years in Catherine's lab in Peter Morris's department. And I worked with a classic model of tolerance in animals, a mouse neonatal tolerance model that had been explored by Peter Medawar and his colleagues, for which they won the Nobel Prize in 1960, and had worked with that model throughout the 50s. And when I sort of came into it as a clinician, I really came into it with the point of view that this was certainly clinically relevant. And of course, that hadn't been the case when this model had been used before. It was very far from being thought of as anything with eventual clinical relevance to children, because children weren't being transplanted, much less adults. So, but I came to it with the point of view that understanding the developing immune system could really potentially help us in dealing with these young children who were having transplants.
And then you went from there back to Toronto.
Right, and so I finished my my research training there and went back to Toronto, where I began, where we had just recently established a heart transplant program for children. And at the time that I returned, I think there had been about 5 transplants done.
And that was what year?
That was in 1994.
Okay, so that was actually just before the baby Faye.
Well, baby Faye was 1985.
Right.
And then 1986 is when Dr. Bailey reported the first successful infant transplant. So by this time that I was going back, that population had grown quite a lot.
So where were you during the baby Faye?
I was still a pediatric cardiology trainee.
In training. So did that have some particular impact on you, or what was your impression?
Well, I thought it was quite daring. Of course, everybody thought it was daring, and What I found interesting about it was that, aside from the fact that this was crossing a species barrier and was the science ready for that, the fact that someone would push something forward to actually try and deal with these infants, remembering that these children all died before. And I remember being struck by the fact that if you went out on a limb and did something different for trying to push transplantation forward, there was great hue and cry. And yet, if these same infants just died, there was kind of a collective shrug. Well, it's a hypoplast. What do you expect? And so it was a really interesting time point there, because you weren't going to get the field moving any further forward without taking some risks. And I think that's where the period of the late 80s and early 90s for infants really opened the door. And then, of course, there were 200 infants transplanted.
Were you aware of his activities in xenotransplantation, which were relatively rudimentary, before Baby Faye?
No, not before Baby Faye.
So you saw it in the headlines and television like all the rest of us?
Yeah.
And what about thinking forward to your later activities, what about the ethical issues? There was a huge public outcry. In fact, there were even death threats to Leonard Bailey. How did that influence you, impact you, and your thoughts about either xenotransplantation or moving the field forward?
Well, I came to know Dr. Bailey later, much better, and I think that when we had such a compelling patient population, certain risks are not only acceptable, but are really necessary to make any progress with a patient population like that. And you can argue, I think, a little bit about whether the science could have been better understood before, should have been better understood before. But what that experience did was really open the door to infants to be even considered for transplants. And that had a big impact on me when I thought about, we can't just take these infants who are born with these seemingly overwhelmingly difficult conditions and not try and push some of these boundaries and question and really ask the question, is that really necessary? Is that really a barrier or an obstacle or something? Or should we really push harder at it?
So now you're toiling away at Toronto Sick Children's and getting into transplantation in sort of the mid-1980s with pediatrics. And eventually, of course, one of the things that you will be forever remembered for is this entree into blood incompatibilities in heart transplantation. So help us understand what initially, before the real impact, what began to set the seeds based on your unique background in immunology and your being juxtaposed in a point of time when pediatric infant transplantation was no longer new, but it was becoming a bit mundane, and especially mundane with the incredibly long waits for donor hearts. Help us understand your sort of state of mind during that time as you were beginning to, those seeds were being planted for the possibility of this new adventure.
Well, I remember starting to think about the developmental inefficiencies or deficiencies of infant immunity, and whether that could be turned from a disadvantage to an advantage for infant transplants. Whereas we think of infants and their immunologic immaturity as hampering their health in a way and preventing them from becoming well immunized against vaccines and so on, and being susceptible to certain infections. But I remember starting to think about it in quite the reverse, where that there were some things that perhaps rendered them actually gave them an advantage in terms of transplantation. And one of those was the fact that they didn't have blood group antibodies early in life. but it was spurred on by a specific case that I remember very clearly. At that time, we were listing babies for heart transplantation, as were other centers, and as you say, during that period of time, it was really very difficult to get donor organs. And there was one particular case I remember that I received the donor call, and a perfect donor, a good function, not too far away, right size, but the blood type was B and our recipient was an O. And as I turned it down, as I was obliged to do, I knew that the patient would die and most likely die in the next few days, which is what happened. But really just thinking about the fact that the regulations that compelled me to turn that down didn't seem to me to match with the reality of a child who was not likely to have the risk factors for which those rules and regulations had been developed.
Now, what was the state of knowledge about ABO incompatibility at that time? Did you ever have any experience giving blood transfusions to small babies that weren't matched? What made you really think that it would work? Did you have insight from other immunologists?
It actually, the germ of the idea came from a very close friend and colleague of mine who is a hematologist in England. And during my time at Oxford, when we'd get together and chat about our respective fields, and we began thinking about, or began talking about ABO blood types, just out of scientific common interests. And as you know, in bone marrow transplantation, which was something that he was doing, blood group incompatibilities are not a big deal. They cross them all the time. And through that, we started just thinking about these things. And the fact that infants don't have these antibodies is a well-known fact. That is not new at all. And I think together, maybe, during one of these discussions, we began thinking, well, would that work? Could you do that? What would you expect? So me as a cardiologist and a transplanter asking him as a hematologist, what do you think would happen? And him being quite surprised, actually, that we thought it was a problem. And together then you start to think, well, maybe this is really a possibility. Then if you take cells that have, as you say, if you transfuse a baby with cells of an incompatible blood type at a very early age, they don't have massive transfusion reactions. And in fact, that's been reported in the early 60s, that could possibly even induce immune tolerance. So once you begin to think along those lines, it becomes, and you start to look in it and think about the possibilities, it becomes more and more obvious that this is a possibility that should be seriously considered. When you couple that with the population we were dealing with, it becomes even more compelling.
Take us through the journey as you worked through discussions with colleagues, their surprise. How many years did it take from discussions before you really began to think about establishing a protocol, and so on?
Well, I think the case that I described that I turned
That was
down,
what year?
I'm thinking that was probably 1995. So it took about a year, I think. Once you start down and sit and put pencil to paper, and you know what it's like. It's the back of well, why wouldn't this work? And then you map it all out and say, well, it should work. And lots of phone calls with my friend back in England just to make sure that I understood the immunobiology, the hematobiology, from the same perspective as he did. Then one team member at a time, I began to speak to our surgeons and to our, of course, to the ethicists. That was a big thing, was to present it as a possibility with a scientific rationale and a compelling reason to the ethics people. Now, this was not a research ethics board. This was a clinical ethics board. What's the right thing to do in this setting? I found them actually very open and willing to consider this, really actually far more easily than I had expected. And so we talked it through a number of times with these people, and they began to come to the general acceptance, but it was always a theoretical until a given time. It was always a theoretical. Well, let's think this through, because at some point there will be a patient and you will need to make a decision. But I found them very helpful.
So take us through the steps. It's become common discussion among you and your colleagues, of course, as those things go, that, well, maybe this could work. So, and take us through the steps and the years of up to the first implant.
Well, so my surgical colleagues were very supportive. John Coles and Ivan Rebecca were involved early on, and as you know, John Coles they both have a very active research interest. So pushing the boundaries at that time was something, the mindset of being aggressive in transplantation was part of how we worked. They were willing to take donors from further away, you know, the kinds of things that you push a little bit to get these children transplanted. So we had the mindset there. That was very, very helpful. The risk aspect of it was not off-putting to them. That was very helpful as we worked through the science of it. But one day, then, there was a call from a patient. And so, you know, we were kind of inching forward, but until there was a patient, this was all kind of sitting there reasoning through it all and saying, yeah, that could work, that's a possibility. That's quite interesting. Yes, the ethics would appear to be, would favor in the risk-benefit decision-making something that could actually be done for these children. I was contacted by, through a friend of mine who's a perinatal high-risk obstetrician from Winnipeg, had come in contact with a family there. The mother, Rita Schroeder, was pregnant, and the fetus, which at that time was probably midway through her pregnancy, had hypoplastic left heart syndrome, had been diagnosed prenatally with hypoplastic left heart syndrome. My colleague came into touch with this family because the family were told by their obstetrician that transplantation was not available in Canada, that there was really no hope for her baby, and that was kind of end of story. You know, there's the collective shrug. Too bad. But my colleague from Winnipeg actually knew that we were beginning to do transplants in Toronto. In fact, by that time, we were doing 15 to 20 a year, so it was becoming a very busy program. The infants, however, for the infants, it remained still very difficult because the organ availability was so poor. So this family called me, and I was somewhere else. I can't remember where I was traveling, but they called me, and we spent probably 2 hours on the telephone just talking through the possibilities.
Of transplant?
First of transplant, because they needed to understand, of course, as all families who come into this situation need to understand all the things about transplantation, especially transplantation during infancy, when we're then facing 20, 30, 40 years maybe, we don't know, of immunosuppression and growing up with a transplant and so on. But during the course of that conversation, I of course was obliged to tell them that the likelihood that that we would be able to find a donor organ for their child was very small, and that in fact over half of the children the babies that we listed, would die without having a transplant. They had some decisions to make too at that time about trying a surgical palliation. So they actually had to choose a pathway, sort of, at that point. Would they prefer to go kind of one way or the other? Things have changed a little bit now, but that's what they were faced with. They also needed to understand that we could list the baby for a transplant during the pregnancy, and that might, again, open the doorway to a few weeks more of being able to look for a heart before the child was born.
And that was what year?
That was late 1995.
95. Mm-hmm. So continue.
So this was a really very interesting family. They had not only a lot of family support, both Harry Schroeder and Rita Schroeder, but between them they had a very courageous way, I guess, trying to think how I would have reacted in that same situation of looking forward at possibilities, understanding that there were no answers and that there was enormous uncertainty in what we were able to tell them. But calmly, it made sense to them. It was logical, and it is logical. In fact, one wonders why this wasn't done before. But so they were very accepting not only of the uncertainties of the whole, was transplantation possible, but also introducing this new concept that could offer them a much higher chance of getting a donor for their child, but the enormous uncertainties of the fact that this had never been done before. But the science made sense to them. Mm-hmm. They were bright and intelligent and well-educated and very supportive of each other. So I described this possibility as well and why I thought that this was a reasonable option for them. They came to Toronto then from Winnipeg when Rita was about 36 weeks pregnant, and their child was listed for a transplant. And we went through it all again at that point. We sat down, we mapped it out, we talked through the science, and again, though, it was a theoretical still, because listing the child for transplant, of course, didn't imply any decision at that point until an organ became available. So the stage is sort of set then. We have a family that, yes, okay, we're thinking about transplantation. We desperately want something to be done. And something is better than nothing, even if something is risky. But these are the risks we're facing. So,
did you have a IRB process?
We didn't, because this wasn't research as such. It was a clinical. It wasn't a trial, really. We didn't set it out as a trial. You couldn't really do that. It was a clinical decision, and so but the ethics panel, which is what it was at the time, helped us through every step. They said, yes, you're going to have a decision to make, likely. If a donor arrives or is identified and it's a blood type O and the baby's blood type O, then clearly there's a path forward. But you may not have that decision to make, and it will likely be with some haste that you need to make that decision. It will be the middle of the night. Everyone is going to be anxious. Things need to be put in place ahead of time. And so, they worked with us with the understanding that the theoretical would become reality at some point, most likely. And they were very supportive. And they said, we will be there that night, when the donor call comes, and if you need to go through this again. But in principle, we give you the approval of the ethics committee that this is an ethical way forward, if you like. It wasn't as regimented as we now are with IRBs and so on.
And?
So the night came. And
what was the blood group of the baby?
So the baby was blood type O. He was 3 weeks old. This was on February 13th, 1996. He was in the...
How long had he been waiting?
So he was born in late January, on January 25th. He was 3 weeks old, and he'd been, as hypoplasts were, his anatomy was fairly favorable. He didn't have as you know, these are duct dependent, and they have to be managed quite gently in the ICU. But his anatomy was as favorable as it could be to need to wait for a little while. But as they do, as the weeks go by, things start to slowly
unravel.
And I'd say that he was right at the right time. He was 3 weeks old. And I had a call, and of course I met with the family. We rounded it.
Blood group of the donor? So
the donor came up, and it was blood group AB. There you are. Now the decision has to be made. So I went into the ICU, and it wasn't the middle of the night. It was daytime, which helps a little bit. And we sat down and talked the whole thing through again. Because as you know now you've really got to make a decision quite quickly. I don't remember how far away, what the geography was, because sometimes that adds to the haste of the decision, as you know. But we chatted for probably 20 or 30 minutes again about the science behind it and why it made sense. But I said, it's really, you need to decide whether you feel compelled by the science enough that this makes sense to take this chance, understanding that we don't know. And there is certainly a possibility that this could all be wrong, and that this infant immune system that we think is not really terribly responsive at this stage to these particular kinds of antigens, we could be wrong about that. And there could be catastrophe in the operating room. And I was very forthright with them, because you cannot be. But they had seen the weeks go by, and you know the stresses on these families as the weeks go by, and you don't know day to day to day whether this would be the last day, whether your child would die tonight, or I mean, it's very heartbreakingly stressful for them. So they were very calm about it and said, you know, we'd like to think about it a little while. It didn't take them long, though. 10, 15 minutes later, they were very self-assured in the decision that they made, and said, we think this is the best chance for our child.
And who is the surgeon?
Ivan Rebecca was the surgeon. And so I, of course, as the family were thinking things through, I, of course, had already discussed this particular donor and this particular recipient with the surgeons again, and set the pathway for the possibility that we would be doing an ABO incompatible transplant that evening. And they were, again, fine with it.
And
Fine with it.
did you have other special conversations about any alterations in immunosuppression? That was all, of course, worked out in advance?
Well, it was, yes, I mean, but it was a fairly standard approach. We didn't think that the aggressive maneuvers that we knew were starting to be undertaken and this was really before ABO incompatible kidney transplantation became a commonplace procedure. But certainly the reports of unintentional ABO incompatible transplants would obviously fill you with dread because they were so dramatic and so catastrophic. And so we had thought through, well, if there is a problem, what kinds of maneuvers could be undertaken? But they're fairly limited at that point. The perfusion team, the perfusionists, were very, very helpful. They were extremely helpful. And they said, well, so there was the immunosuppression plan, which was worked out to be probably just what we do for the compatibles. Because if the science is correct, in fact, you shouldn't need any further aggressive maneuvers. We talked about one of the kind of difficulties was we were going to need an assessment of antibodies, both going in and during the procedure, and several times. And the blood bank that was going to run the test for us was somewhere else, and so we needed a runner to take samples and sort of. So we sort of put those things into place so that we would have as much information as possible.
Did you do anything about exchange transfusion or exsanguinating the baby into the pump in that first case, discarding that blood and filling it with blood group O?
Yes, we did think through those things, and we thought the safest thing would be to, as we were going on pump, to just remove, even though we had tested the antibody titer and it was low, nonetheless, we felt that if there was any likelihood that antibodies would be starting to be produced rapidly, if we could continue to remove them through the bypass circuit and and replace with appropriate blood products, that would be the best way.
So the anti-A, anti-B antibodies were low, but not zero.
They were low but detectable, if I remember correctly. Nowadays, I'd look back, I mean, it wouldn't bother us at all, but we didn't know whether that would be an indication that the B cells that would be, are they really unable to respond? Are they really? Can we really be certain of that? Well, you can't really. At least we couldn't then.
So they were working to add blood and remove blood during the case.
That was the plan. The perfusionists really were key in the preparation for the transplant because they had it planned out. Which blood products are we going to use? How are we going to do the blood products? Which ones are going to be, what should we use to prime the pump? Should we use AB or should we use O?
And the decision?
And the decision, and again, it's very logical as you think it through. Well, this baby is blood type O. The blood bank is going to send us blood type O blood products. This is a problem because they will come from adult blood donors who make anti-A and anti-B antibodies. So as we thought that through, it became quite obvious that this was, in fact, the trickiest part, was to get the blood products right. And so the decision was to use type AB plasma, type O cells, and then we had a bit of a discussion about the platelets, and well, okay, platelets carry the antigens, and they have a lot of plasma in them. So AB platelets would carry more antigens, but would lack the antibodies, whereas O plasma would not contain the antigens, but would have a lot of antibodies. So you're kind of going through these, because those were decisions that actually had to be made right then. And we, of course, it's all logic, so you want to avoid the antibodies. And so blood type AB plasma was used, blood type AB platelets were used, and plasma products, and the cells were blood type O. That seemed logical, and in fact it was, and that's still what we do today.
And so that baby did well?
So then the family came back and said, yes, we think this is the right way forward. We headed into the operating room. We went through these various decisions about how to get on pump. The blood bank, though, it was very interesting because I'm kind of a hanger out in the operating room, and I needed to take these for my own peace of mind, since I'm not actually doing anything except hanging out and being worried. I could take the samples to the blood bank and harangue them and saying, we need to know as soon as possible whether there's, by the qualitative testing that they do, any antibody here. I'll call you in 5 minutes. So there's this back and forth while the surgeons are just calmly doing the transplant, of course. There was certainly anxiety on my part, and I made a few last-minute phone calls, I'll confess, to colleagues for moral support, even though I wasn't a surgeon. But I remember Ivan putting his hand on my shoulder as we went in and saying, you better be right about this. And I called Carl Cardella, who's a transplant nephrologist in the adult world, and he had talked it through with me several times too, with long-standing interest in antibody. And he said, no, it'll be fine, don't worry about it, it'll be fine. The science is right, it'll be fine. So the operation proceeded, and as we came off pump, I remember hanging over the table and not seeing what I wanted to see right away. And there's that little lag sometimes, and the heart was perfused, and we'd had several negative samples called up from the blood bank. No, there still are no, we can't detect any antibodies. But there was a moment there, as there sometimes is, where things didn't start right away, and I really was tremendously anxious that that was related to the blood group incompatibility, but it wasn't, and quickly enough, the heart started pumping and was perfused, and there were no issues, and it became a regular, that's from there on was just a regular transplant. The baby did very well. As we came out of the operating room the next morning, the father, Harry Schroeder, we said he's doing well, he's fine, he's actually done very, very well, and he said, it's Valentine's Day. This is a wonderful Valentine's present. This boy did very, very well. He's now 15 years old. He has remained, all transplant patients have their ups and downs because of the anti-rejection medications, of course, as has he, but generally speaking, he has done really well. He's on monotherapy. He's a little bit hypertensive, but he's had very few of the side effects, of the chronic side effects. His kidneys are still in good shape. He's a happy, healthy boy. So it was a great success.
And was there much local media attention to this, or was this not really appreciated?
No, not then. No, it wasn't appreciated then. It was a huge success for us, but it really wasn't until the experience grew that it became understood how unusual this was. So the next case came along, and the next case, and by the time we had done 10 incompatible transplants, and really had had no unexpected problems compared to a ABO compatible transplant. The blood type products, the blood product issues became very well understood and more or less routine.
So the blood products have been worked out, and you've done now 10.
Yes, so now you start to push it a little bit. And there was one baby, there were 2 babies who were 14 months old in that first cohort of 10 patients who were compelling because they were older, and we did not have anywhere near the same assurance that this would be successful because they already had, at 14 months of age, developed antibodies, donor blood group antibodies. But when you start, you know, again, the compelling nature of the patient population pushes you a little bit, and those children actually, we were able to remove the antibodies, and they did. They were able to be successfully transplanted. One of them died at about a month post-transplant due to other reasons. But I think at that stage, you're getting into an area of immune development that we don't really understand so well. We don't know the limits of it, and we don't have that many ways to really very solidly assess it.
And before you formally published this, were there others through your mutual conversations that began this experience as well?
Well, so we started talking about it a little bit, but we hadn't. People were generally very skeptical, very dismissive. Oh, you can't do that. That doesn't. You must be crazy. You know, I mean, really looking at you saying you can't. Just disbelief, really, even with close colleagues that we all work together. And if I said that to you, I mean, you might meet it with an understanding, but many people said, well, that's just terrible. That's ridiculous. How could you possibly take that risk? And then you talk it through with them and say, well, because it works. It works, and these children are being transplanted. But really, it was until we published it, and then, of course, there was lots of discussion about it. But group by group, if we did talk about it and talk about why we were doing it, and there was absolutely no interest in adopting it anywhere else, really.
Fascinating. So then at some point in your career, you elected to leave Toronto for other opportunities. Tell us about that.
Well, our program grew and grew. It became very, very busy. The scientific side meanwhile, of what I was trying to do as a transplant immunologist was also growing and had actually been much influenced by what came out of the ABO story. I was working with animal models of tolerance. The ABO story was clinical, but the immunologic consequences of these children growing up with an incompatible heart became, to me as a scientist, equally compelling as the original clinical story of being able to find donors for these children, because the immunologic development mirrored exactly the animal models or very closely the animal models that I was working with. As a scientist, this was tremendously exciting and opened all kinds of new doorways into understanding with more clarity not only the development of the immune system of young children, but the opportunities potentially for intervening in beneficial ways and inducing tolerance, because these children develop tolerance to the blood group, immunologic tolerance, in very much the same way the animal models do. So opportunities became available that allowed us to really embark upon a much more expansive investigation of these issues at the University of Alberta in Western Canada. As it turns out, Ivan Rebecca was the surgeon there at that point and was instrumental in recruiting my husband and I to the University of Alberta, where the resources available for research were really very favorable and have allowed us to move this forward and build it not only nationally but internationally, and really it's taken on a whole new life now.
You also had a different course related to many professionals who are joining organizations like ISHLT or other transplantation societies. Tell us some of the issues that you face and decisions you make in terms of allocating time and energy to one or more societies in terms of heart and lung transplantation versus general transplantation and immunology. How have you made those choices?
Well, my training in immunology and transplant immunology took place in a setting that was not at all cardiac or thoracic related. I was the only thoracic person, actually. I'm thinking back now. During the time that I was in Oxford and learning immunology, people like Chris Larson and Tom Pearson and Bob Montgomery, who are really renal-based people, were all there as well. It was very much more a kidney transplant-based community, but it was the science that was important, and becoming educated in the science of transplantation in that setting allowed me to develop interactions that have served very well to anchor me broadly in transplantation. I think for heart transplantation that's very important because, I mean, let's face it, the kidney transplant community has huge numbers of patients with which to inform the science of the community and vice versa. So I think that can be very beneficial for us in thoracic transplantation where our numbers are much smaller because things are often, clinical pathways can be explored in kidney transplant patients, of course, much more easily sometimes.
So as president-elect of ISHLT, what do you see as realistically as our future in this society in terms of embracing the science of transplantation when there are economic constraints about how much people can travel and really invest their time? Are we going to be able to compete for the science in transplantation compared to other more general transplantation societies? What do you see as the trends for the future for this society?
Well, I think that the key word is partnerships. Because we have a unique population that's quite different from, of course, is quite different from the others. And we have different scientific questions that can be guided by the understanding of developments in those other more general transplant areas. But we bring to them very interesting and novel aspects of the science of the organs we deal with. I think that partnering with other societies is the key to this. We need to be integrated, not as joined societies necessarily, but there are abundant partnership opportunities where we can learn a lot from them and they can learn a lot from us. So that's what I see are the key interactions. The science of the scientific pathways that are involved in our community have a home here that is different, and they can't find that maybe over here. But it's because we're dealing with things like stem cells and their use in cardiac replacement, for example, or transplant immunology, the way it relates to heart and lung, which is quite different and really can't be done over here, but we can do a lot together. And so I think to set out for the young people coming along, the need to be part of a more integrated community will be very helpful to them. And I think that focusing on the science in this area and pushing it forward is really of key importance. It's fundamental importance to this society because, as we know, we can't move the field forward if we don't understand the science behind it. In mechanical circulatory support, for example, there are all sorts of really very interesting and compelling scientific issues that are being studied, and this is one of our key populations. So we need to bring the science in that's connected with the organs that we transplant. The other, and it is a time challenge. Of course, there are only so many things, but as we connect these people up, I think that's where they'll be able to find the ways, the people they need to talk to, the networks they need to make that will help move the field forward on all fronts. The other aspect I think that's really important for our society is in international advocacy, and that primarily, I think one of the biggest steps there is addressing the issue of deceased organ donation globally. And this is we are completely dependent on deceased organ donation in our field. We have very few opportunities for living donation, in lung, of course. And so understanding the global developments in organ trafficking to try and have an impact on that, but most importantly, the global trend toward encouraging self-sufficiency in organ donation, one society to the other, one culture to the other, one country to the other, is something that I think we can play an enormous role by joining the advocacy efforts that have been initiated through the World Health Organization. And I'm really looking forward to us being more participatory in that.
Great. Thank you very much.
Thank you.